Hello, my name is RichardBoies. I'm a member of the Unit 3 East at the Southern Arizona VA healthcare system. I currently work there as a staff RN. Through this slideshow presentation, we're going to explore the dynamics existing on the Unit 3 East, where I work. 3 East is a dynamic acute care medical unit that focuses on the veteran population's complex medical needs. With the aging veteran population, we are presented with more chronic age-related conditions that continue to complex the medical needs. Patients with dementia that present on the unit these days tend to present unique challenges in the transfer and progression of these patients through the system to more appropriate levels of care. Leadership employs the healthy work environment concept that positively influences relationships between leaders and staff on the floor. It fosters improved unit relationships by developing trust amongst the staff, and it fosters a kind of a mutual effort towards the unit's mutual goals. Healthy relationships between staff and leadership do positively affect unit morale and professional satisfaction with job performance and work. The organizational culture of 3 East tends to be a supportive environment based upon the account and respect amongst team members. The supportive environment is created by leadership in order to create a more trusting and team approach towards addressing patient care issues of the unit. As a result, nurses' job satisfaction does increase and is related to and has a direct relationship to the patient satisfaction of the unit. Like I said, happier patients tend to make happier nurses, whereas happier nurses make happier patients. It works hand in hand, and like I said, with the positive correlation, it just makes sense to everybody work together. The patient-centered care model of delivery on 3 East tends to make the patient an active participant in their own care on the unit. We emphasize patient preferences, physical comfort, emotional support, information, education, and inclusion of the family within the care. We want the patient to exercise their preferences and be included into the choices that surround their health care issues instead of just being, like I said, funneled through the system mindlessly. We find outcomes with therapies and patient satisfaction scores are positively influenced when this is taken into consideration when the nurse plans for makes care planning for the patient. We on 3 East are a staff that is dedicated towards preserving self-determination and patient autonomy in healthcare issues. Like I said earlier, makes them easier to deal with and as an active participant in their care, and instills a lot of control in an otherwise uncontrollable environment for the patient. Patient-aligned care teams are the framework we use at the VA hospital to create an interdisciplinary model of care for the patients that come through there. Teamwork between physicians and nurses, along with other entities such as social work, pharmacy, and other systems within the VA is the basis of this model. Teamwork is key. The patient outcomes become positively influenced by this team approach because all aspects of patient care are addressed by all these professionals, and a comprehensive plan of care based upon all disciplines is created so the patient can be more progressed towards discharge and home. The computer systems we use over here on 3 East would be VISTA, which at first was the Veterans Health Information System and Technology Architecture, along with CPRS or CPERS, which is the Computerized Patient Record System, and BCMA, which is Barcode Medication Administration. These are the main systems we use to manage patient information within the environment of 3 East. Nurses are all have their level of are authorized to access these systems to aid in patient care. Security is ensured by our security personnel through personal identity verification badges, or otherwise known as PIV badges, and the system is also password protected. Access to this system is available to all authorized providers within the system, and it makes accessing records much easier, whether you're at a VA in Seattle or as compared to Phoenix or Denver. The information follows the veteran anywhere they go within the system, which does a lot to sit there and produce safer outcomes for the patient. Using the Just Culture model on the unit for healthcare delivery improvement, both nurses and leadership benefit from this process. With the Just Culture model, learning replaces blame when it comes to errors in like medication administration or documentation errors or other things like that, because sometimes the nurse really isn't to blame. Sometimes it is the system that needs improved, and this is one of those unique opportunities in which the organization can improve its systems. So instead of creating a system, an environment where the nurse is afraid to self-report medication errors or engage with leadership on patient care issues, problem solving takes the place of that, to where teamwork and accountability and problem solving replace the blame. The safer environment definitely corresponds with the non-threatening environment created by the Just Culture model. Nurses are allowed to participate in the system's improvement project. Staff are often invited to engage in what we call the quality improvement process there at the VA. Staff are included to sit there and find ways to make positive changes to improve patient care outcome and satisfaction on the unit. Because of the complex nature of our unit and within the environment, constant reassessment and adaptation of these systems is required, because patient needs do develop over time. As when they come in on discharge, very acute pain care needs may be there, whereas you progress to discharge, needs may progress more towards social work and outpatient needs. So this is why this has to constantly change, because the system itself adapts constantly. So with this model, there are many opportunities for nurses to engage in these processes to affect the change for patient care, and oftentimes sometimes lead to greater job satisfaction throughout the system. With the aging veteran population, more and more incidences of admissions dealing with that are complicated by dementia and other neurocognitive disorders tend to present themselves more often on the unit. As a unit, we do our best to address these issues, but patients with dementia do present unique challenges associated with transfer and progression through the system, and acquiring more appropriate levels of care for the patient. Delays in this patient progression not only negatively impact the patient outcomes associated with patient care, but also disrupts services system-wide in the ability that we as a unit are no longer, the bed is occupied by a patient that no longer needs it, but is just there because they've got dementia. And the emergency department cannot admit patients into the unit because beds are being held up for this issue, and then that further backs up the emergency department to where we can no longer effectively admit patients in a reasonable manner. So as you sit there and see, not only does it have negative outcomes for the patient, but negative outcomes system-wide for the hospital. Collaboration with nurses and physicians guiding the care of these patients with dementia need to collaborate and create new strategies and protocols that basically would be nurse-driven to deal with the acute episodes that are encountered by episodes of confusion and agitation related to the dementia that sometimes lead up to violent episodes. Delays in these acute events often deteriorate patient progression based upon safety issues such as increased falls and injuries related to confusion and disorientation to the unit. I also propose the use of to update and standardize the use of SBAR communications for nurse-to-nurse communications between the units, and create to develop and utilize standardized checklists between the units so that to delineate the needs of the unit for patient progression to the other system, instead of leaving it up to chance, and hopefully we do remember everything. Using the checklists, both units can go down it and make sure everybody's got their ducks in a row for when time for transfer to the next level of service is ready. Everybody's ready to go. No longer would discharge be delayed because the potassium was 3.8 instead of 4.0, which is normally rectified through oral potassium supplements, or the fact that the patient has got a sitter overnight and cannot and the unit cannot no longer accept them because of that. Progression would be expedited by using these protocols, and also creating avenues to sit there and streamline admission, transfer, and discharge protocols throughout the system to aid in transitions between these services. Well, that's the end of my PowerPoint presentation. I hope you all really enjoyed it. We've covered a lot of information, and I was able to introduce you to the Unit 3 East, where I proudly serve the needs of our veteran populations. And I hope I was able to bring to light problems associated with patient progression throughout the systems with people with dementia. Not only does the VA hospital suffer from this problem, but many other hospitals within the healthcare system also deal with this problem too. Anyways, thank you very much, and goodbye.